Hello and welcome. I am Dr. Tracy Richards. The topic for this webinar is supervision of counselors in integrated care settings. Integrated care settings, as you may be familiar, are settings in which care is highly coordinated between medical providers and behavioral health providers. We're often working side by side, assessing, diagnosing, and treating shared patients, typically sharing a treatment plan and meeting together frequently. Within this setting, the behavioral health provider can come from a variety of disciplines, typically marriage and family therapy, counseling, social work, or psychology. When selecting a behavioral health provider, if the individual is a practicum or internship student or pre-licensed, sometimes called license eligible, then they will need a supervisor. Regardless of the discipline, supervision is necessary. Each discipline has different supervisory requirements, and those requirements may differ from state to state. Supervisors and supervisees should be familiar with their state-specific supervision requirements. Specifically for counselors, you can see I have the website pulled up. It's counseling.org. Their supervisors must have a master's degree in counseling. Some of the hours of supervision can be obtained from a related profession with equivalent qualifications, but not all of the hours. For the most part, their supervisor must have that master's degree in counseling, 2 years of pertinent professional experience, and relevant training in counseling supervision. So let's get down to brass tacks and define supervision. The etymological definition of supervision is to oversee. It's not just vision, it's supervision. Supervision is an intensive, right? So we're intensely focusing on mental health, interpersonally focused, one-to-one relationship in which one person, the supervisor, facilitates the development of competence in the other person, the supervisee. Furthermore, the supervisory relationship is evaluative and hierarchical and extends over time. Supervision is an intervention provided by a more senior member of the profession to a more junior member or members of the same profession. Though it is important to recognize, just because a person has mastery in the field does not mean they will be equally good at supervision or at supervising. Clinical supervision and integrated behavioral health have much in common, but they also have separate and very distinct skills. Supervision has similarities with other professions, but also important differences. You'll notice that similar to teaching, in supervision, we're wanting to impart new skills and knowledge and to evaluate the individual. However, in teaching, there's a curriculum, whereas in supervision, it's driven by supervising needs. And similar to counseling, supervision may address behaviors, thoughts, feelings, and often explore values and biases, though the purpose of these explorations is not necessarily personal growth, but increasing effectiveness in working with clients. Additionally, there is an evaluative component to supervision that isn't part of counseling. Just as in consultation work, supervision assists supervisees in being more effective professionally. The difference, again, being that supervision is evaluative and hierarchical and occurs across time, whereas a consultation is not necessarily a weekly scheduled event. It's more likely to be a one-time event scheduled as needed, which is what supervision begins to look like for the more advanced supervisee. The key takeaway point, though, is that supervision is not synonymous with counseling, teaching, or consultation, though there are overlap in the roles. And in fact, one model of supervision, the discrimination model, capitalizes on these overlaps. Clinical supervision is a complex activity with numerous models and theories to choose from. so many that there would not be enough time to go through them today in this presentation. It's just beyond the scope of this presentation, but know that supervision is a competency all of its own. So why do we supervise? The purpose of supervision, there are two main ones. One, to foster the supervisee's professional development, and two, to monitor the quality of professional services to ensure client welfare, and therefore serve as a gatekeeper to the field. Just as practice managers, medical providers, and the behavioral health provider need to be aware of the core competencies, supervisors need also be knowledgeable of them. In quick review, the core competencies are listed here. And for those who may not be able to see my screen or read that those words, I have interpersonal communication, collaboration and teamwork, screening and assessment, care planning and care coordination, intervention, cultural competency and adaptation, system-oriented practice, practice-based learning and quality improvement, and informatics. Those are the core competencies of integrated behavioral health. According to SAMHSA, the supervisor benefits from being knowledgeable on these competencies for several reasons, and we can use them in several ways. I'm going to go through each of the ways. For one, the competencies serve as a reference point when designing and delivering trainings or in-service education. The images I've added are snippets from a syllabus from a course entitled Integrated Care for Children and Youth. It's a course I taught this past spring. When I design courses, I imagine the course has long ended, and I ask myself, what knowledge and skills do I want the student to have retained and be implementing as a result of having taken my course? The competencies serve as a guide to answer that question, so the instructor or the supervisor can know what activities to include and topics to cover. The competencies inform the job description and duties. The images show a job description and a flyer announcing an integrated behavioral health provider. When bringing someone on board, the core competencies delineate what the provider will be doing day to day. The competencies are therefore used in the recruitment process to educate candidates about the nature of the work and expectations. You can see a list of sample questions that can be used. If you're wanting to find a candidate and you know in the core competencies that they need to be effective with interpersonal communication, that question 3 there says, how would you resolve a difference of opinion with our medical provider? So it might give you an idea based on their answer how effective they are at that interpersonal communication. Another example is, that care planning and care coordination. If we know that that is going to be a frequent part of their job, we may want to inquire if the candidate is knowledgeable of local resources. The competencies can be used as a guide for orienting new employees or supervisees to their role and responsibilities. The images are a snapshot of some of the orientation presentations that I recently used when onboarding new supervisees. I typically offer an in-person orientation, but this semester with the pandemic, we had to get creative and post the recorded presentations on the university Blackboard forum. And lastly, SAMHSA identifies that the competencies can form the foundation on which performance assessments are based. Now, this image is the first page of several pages of the Behavioral Health Consultant Core Competency Tool. It uses slightly different competencies than SAMHSA, but serves to show my point that we can utilize the competencies to assess performance. The tasks of supervisors, you may be very familiar, include signing off the client documentation as needed, viewing the supervisee recordings, challenge the supervisees to justify approach and the approach and the techniques that they used, Support the supervisee's development as a counselor, present and model appropriate directives and interventions, intervene when client welfare is at risk, ensure ethical guidelines are upheld, monitor supervisee's basic attending skills, and then at the way that my clinics are set up, the supervisor is expected to meet for 1 hour of supervision of supervision. So I provide the supervision to the supervisors, and they're also expected to attend staff meetings. They're expected to inform me, the supervisor of supervisors, of any ethical and legal issues, and they should be utilizing those supervisor models and theories, so beginning to conceptualize students. The image is of a conceptualization from that discrimination model I mentioned earlier. At a glance, reading through these different tasks, it may not seem that different. Where it really starts to get different is in the knowledge and awareness that the supervisor has. Edwards and Patterson suggest supervisors add the following skills to be effective in supervision in integrated settings. And these are to understand the medical culture, locate the trainee in the treatment system, investigate the biological health issues, and be attentive to the self as therapist. So, you know, the supervisor of students in medical settings really need to have these areas of competence. We'll go through each of them. Supervisors of integrated health are effective when they're familiar with how a healthcare practice works and how a behavioral health provider operates within that medical system. To make an understatement, medical settings are different than traditional mental health settings. The image you see is a traditional outpatient mental health setting, and so much intention is put into creating a soothing and calm setting. We got cushy chairs, pillows, low soft lighting, natural light. The provider meets with the client for 45 minutes to an hour. In stark contrast, you can see that the medical setting, space and time have to be optimized. They're at a premium. The exam rooms double as the therapy rooms. Everything from the collaboration, the intervention, and the documentation are typically concise and brief. A supervisor not familiar with medical culture may find themselves unable to offer effective guidance and may even find themselves upset over the site-specific nuances. For example, seeing a video clip of a student and it's only 20 minutes long, or the video shows the supervisee sitting on a stool in the medical exam room, austere lighting, and that could cause miscommunications and could make it for a tense supervision session. Also, and more importantly, when a supervisee queries about medical culture, such as the difference between a charge nurse and the nurse supervisor, how to assess and document dementia, any number of things that is common in that medical world, the supervisee would benefit from informed and direct responses, and they're going to best get that with a supervisor who understands that medical culture. Supervisors are effective in integrated health when they assist the supervisee in determining his or her role within the healthcare team and how to function efficiently and effectively as part of that team. Many clinicians, especially those novice to integrated care, are often forgetful of being part of a treatment team. They're used to being in a silo. As a supervisor, remind and encourage supervisees to include the medical team. Talk with the assigned nurse or the physician before and or after sessions. Collaborate. It's important to include in one's conceptualization the physician's perspective. As Edwards and Patterson explain, and I'll quote, knowledge about the physician's perceptions, expectations, and ongoing involvement is an important part of therapy in medical settings. Therefore, important supervision questions that become critical are who referred the patient? Who's the patient's doctor? And what is the doctor's perspective on the patient's presenting problem? Supervisors of integrated health are effective when they facilitate the conceptualization of health conditions through a systemic and relational lens and concisely communicate that to the treatment team, that psychological, social, and relational information. We are often the main investigators of that data. Supervisees at my sites are encouraged to read through the medical chart to become familiar with patients' medical diagnoses and to think in terms of the interconnectedness of the mental and the physical health. Recently, we had a client in her late 70s presenting with psychosis who had never had such symptoms in her life, was diagnosed in her chart with a urinary tract infection, and the supervisee was surprised to know that the UTI could have that impact on one's mental status. That learning curve, the connection between the mental and the physical is a constant learning curve for us at the clinics. Supervisees are encouraged to consult with the medical members of the team, or I'm not going to lie, we use Google to gain clarity on the biomedical aspects that that we may not be familiar with. This information is valuable when conceptualizing the client. And in addition, the medical team has come to value that the social and relational information that we're able to provide, that the biopsychosocial lens, and we do a biopsychosocial written report. There have been many times the supervisees have been able to expose important life circumstance that lend itself to the medical treatment. A recent situation I can think off the top of my head, I have supervisees at a cardiopulmonary rehabilitation clinic, and whenever a supervisee discovered that substance use was part of a client's lifestyle, it became very helpful for the docs to know that. Supervisors of integrated health are effective when they encourage the supervisee to think about how health conditions can impact families and social systems, as well as the supervisee's own experiences with illness and the potential impact of their interaction with patients. I accompanied a practicum student to observe him conduct a session with a patient in the ICU. And as we walked into the ICU, I noticed the student had become uneasy, asked if he could just observe the session, and I acquiesced. When we came back to the preceptor room to debrief, the student became emotional and disclosed that the last time he had been in that ICU, his friend was there after an accident and had passed away shortly thereafter. So in supervision, students need to process through these emotional reactions to things that may not necessarily be site specific to the medical realm, but seem to occur at a higher frequency than in other non-medical settings. And these things include patients being frail and ill, patients being naked, patients being inappropriate due to delirium or dementia, patients continuing to engage in lifestyle behaviors that will ultimately lead to an untimely death, and patients dying. Many supervisees have family of origin and/or existential issues activated during the course of their work in this setting. Supervisors need to be prepared to process through these concerns and also keep an eye out for impairment, which brings up some ethical issues I'd like to review, impairment being one of the ethical issues to keep an eye out for as a supervisor, but the others are due process. The supervisee should be appraised of the academic and performance requirements and program regulations, receive notice of any deficiencies, be evaluated regularly, and have an opportunity to be heard if their deficiencies lead to a change in their status. So if they're going to be put on a probation, they need to be notified beforehand of that process. We have just recently had a student we identified as practicing while impaired, so we immediately stopped the supervisee from seeing clients, and we created a development plan that included listing our concern and the plan to get the supervisee back to functioning. Another legal issue is informed consent. Supervisees should be informed of several things, and we do this through the supervision contract. And in that supervision contract, the supervisee is informed about their what the personal and interpersonal strengths required for them to, for retention in the training program, the conditions that dictate their success or advancement, the responsibilities of theirs, and the responsibilities of the supervisor. And our contract lists the expectations of supervisees are to meet with the supervisor for 1 hour each week, come prepared for supervision. They have to submit requirements. These are often university requirements, but some are site specific. The evaluation documentation, progress notes, videotapes. They are expected to adhere to ethical licensing and legal issues, principles, though they don't know what they don't know, and I'll speak more on this later. But for that reason, we expect them to share complete information regarding the clients and documentation, and they're expected to abide by the supervisor's final decision regarding the client's welfare. Expectations of the supervisors are that they're going to focus on the professional and personal development, address skills and competencies consistent with expectation of practicum and internship students. They're going to assess the skills and competencies at the onset and throughout the training experience. And the clarity that while this is not therapy, right? Therapy and supervision are not the same thing, but we are going to explore values, beliefs, interpersonal biases, and conflicts that may be sources of countertransference in the context of case material, because that is really relevant in supervision. And then supervisors are going to complete the tasks of a supervisor that we've kind of already gone over. And the supervisor must ensure clients have been informed by the supervisee regarding the parameters of therapy and the parameters of supervision that will affect them. These are just some snippets of our informed consent, and you can see it's mentioned that this is an integrated care setting, so the electronic medical record is shared amongst the entire medical team, and also expresses the limitations of using student clinicians. So then clients are aware that they are, having services provided by a non-licensed counselor, and that non-licensed counselor is receiving weekly supervision. And many of the sessions may be videotaped, and that the supervisor is going to view that session. And sometimes other counseling students may view that session, right? But the purpose of that recording isn't about the client. It's about the supervisor being able to provide feedback to the supervisee and ensure that the client is receiving the highest quality of service. Also, when we use students as the counselors, they have limitations as to their availability, right? They're only available certain times during the year, and they're not obligated during their semester breaks or after their semester ends. So this, keeping the clients informed about those important aspects. The supervisor is responsible for preventing supervisee ethical transgressions and responsible for aiding the ethical development of supervisees. And though there is no foolproof way to ensure that ethical behavior of supervisees all the time, but we can do things like take a proactive supervisor posture, right? Be proactive rather than reactive. Use preventative education and have honest discussion where the supervisee feels comfortable and safe to bring up all aspects of the cases. Those are some good strategies. It's also imperative that the supervisor accept responsibility for raising the topics and being comfortable to bring up those issues. Hey, let's talk about, sexual attraction, between yourself and the client. Let's kind of role play through that, or, simulate or behavioral rehearse those scenarios. Many ethical mishaps result from acts of omission, not intentional malice. And so omissions are more likely if professionals have never had an opportunity to experience the ins and outs of that situation. So kind of simulating that situation or behavioral rehearsal of those situations are just ways that safely allow the trainees and the supervisors to explore that situation, try alternative resolutions, and evaluate outcomes. It's, methods for the supervisor include, reviewing the videos, using a pre-supervision screening, which is there on the screen, and then also doing a caseload review. I tell my supervisees that I don't look good in orange, so please be transparent with what is occurring. The truth is they don't know what they don't know. Supervisees often catch the obvious ethical legal issues, but even then they may not know exactly what to do or who to notify. And there are situations that come up that may be more subtle when a supervisee may not even recognize the situation as ethical or legal issue. To those who are currently supervisors or will be supervisors, I strongly encourage reading through the best practice and clinical supervision guidelines available on the ACES website, acesonline.net. It does not include best practices for integrated health settings. However, Pratt and Lamson posit that different levels of collaboration require different levels of supervision, and their guidance for integration at levels 4 and 5 are that supervisees benefit from having a supervisor on site from their given profession, which is the model I use for the sites that I'm at. Supervisees are assigned a supervisor, but there's also always a supervisor on duty in the preceptor room that students can stop by at any time and process through and debrief cases. Supervisors and supervisees should meet frequently. Common supervisory issues at levels 4 and 5 are assisting supervisees on how to introduce themselves to the patient. In the inpatient setting, even where we stand and how we interact with the patient needs to be thought out. Do we wake the patient? What words do you use? If you say, I'm a therapist, the patient may confuse you for the physical therapist or the occupational therapist, and what to say if there are visitors in the room. All of that needs to be practiced and explored with the students. In the outpatient setting, and doing those consultations, how do you walk into a room, and it's usually a room where the patient isn't expecting a behavioral health person to come in the room. They're often only expecting to talk to their PCP. So how do you make your introduction and build rapport in those settings? It can be a challenge and definitely important to discuss in supervision. And the second thing, how to conduct effective and efficient mental health assessments. That can be a challenge, and being able to word it in such a way that the physician can make sense of it and use it to benefit the health plan. How to concisely communicate to the PCP or healthcare providers any relevant mental health content that was provided to the patient during the mental health part of the visit. I encourage students to use the bottom line up front concept and be mindful of language. Our medical team may not be familiar with some of our terms like enmeshment, and likely they don't need to know all of that. Our medical teams are typically interested in symptomology and the quantification of the symptomology. Being able to say to the provider, for example, The patient's score on the MoCA was 13, and that score indicates cognitive impairment. The daughter mentioned to me that the patient is still driving. I think it's time we, have that talk with the family about their mom's limitations. It's brief, it's upfront, it gives exactly what the doc needs to know, no more, no less, and that can be helpful. Also, how to treat patients in a shorter duration of time. Sometimes it's just a consult, a single session, how to have an effective treatment in single sessions, and how to have shorter sessions, 15 or 20 minutes compared to 50 minutes. That's quite a difference than students are used to, and not how they're typically trained. And how to document progress notes in a way that's valuable to an integrated healthcare chart and into the system. We tell the supervisees, don't make the medical team scan your whole note for the piece of information you need them to know immediately. Put what you need them to know in bold, or sometimes, depending on the situation, we have them put it right at the top of the note. And just the way we have the notes written, we spell out the headers so they know this is the mental status exam, so that when the medical team is scanning visually through the note, they can get to the information they need to see quickly. These are my references from this presentation. And if there are any questions or comments, perhaps there'll be an opportunity to explore those in a discussion format later. And I'd like to thank you for letting me speak on this topic.